Hello, today I'd like to talk about subacute thyroiditis through several clinical cases. The patient initially presented to an outside clinic with neck pain, and ultrasound revealed a large hypoechoic lesion in the thyroid, initially suspected to be a tumor. Fine needle aspiration of the left thyroid lesion confirmed the diagnosis of subacute thyroiditis. However, due to concern for possible malignancy, the patient was referred to our hospital for further evaluation. 2 months after the initial ultrasound, the previously noted hypoechoic lesions had completely resolved. Considering both the FNA results and sonographic changes, a diagnosis of subacute thyroiditis was confirmed. Another patient was incidentally found to have an ill-defined hypoechoic lesion on ultrasound at an outside clinic. FNA was performed, leading to a diagnosis of subacute thyroiditis. The patient sought further evaluation at our hospital, and on follow-up ultrasound 9 months later, the original lesion had resolved. But a new, similar lesion appeared in a different area. The patient had been asymptomatic with respect to pain from the outset. A third patient underwent ultrasound for left-sided neck pain. An ill-defined hypoechoic lesion was seen in the left thyroid, with additional hypoechoic areas in the right lobe. Subacute thyroiditis was diagnosed and symptoms improved with treatment. However, on follow-up, new hypoechoic lesions appeared in the right thyroid. As demonstrated in these cases, typical features of subacute thyroiditis include neck pain, ill-defined hypoechoic inflammatory lesions on ultrasound and migration of lesions over time, with resolution of previous areas and appearance of new ones elsewhere in the thyroid. One patient had 2 thyroid nodules. FNA of the smaller one showed atypical cells, while the larger lesion was benign. 6 months later, follow-up ultrasound revealed interval enlargement of the larger lesion and new hypoechoic inflammatory lesion in the right thyroid, which was also painful. Based on sonographic changes, subacute thyroiditis was diagnosed. FNA was repeated on the small lesion per patient request, and this time it revealed suspicious for malignancy. The patient underwent surgery 6 months later, and preoperative ultrasound showed resolution of the subacute thyroiditis. This case illustrates the dynamic nature of subacute thyroiditis over time. Subacute thyroiditis is believed to be caused by a viral infection. It often occurs following an upper respiratory tract infection and typically resolves spontaneously over the course of several weeks to months. It is more common in women in their 30s to 50s. Patients may present with fever, malaise, thyroid enlargement, and localized tenderness. Treatment is generally symptomatic based on the severity of symptoms. Subacute thyroiditis causes destruction of thyroid follicular cells, leading to temporary thyrotoxicosis, followed by transient or persistent hypothyroidism during recovery. Histologically, it is characterized by granulomatous inflammation. Laboratory findings may include elevated CRP and ESR, and reduced radioiodine uptake on thyroid scans despite clinical hyperthyroidism. There are 2 important cautions to consider in cases of subacute thyroiditis. This patient had 2 cancers in the right thyroid. While preparing for surgery, the patient developed subacute thyroiditis. The cancer in the upper thyroid was easily visible because it was not affected by inflammation. But the cancer in the lower thyroid was more difficult to distinguish due to the overlying inflammation. Let's look at the transverse ultrasound video. I will now show you the longitudinal ultrasound video. In the longitudinal view, the cancer in the lower thyroid appears somewhat better defined. When inflammation is present, it is important to remember that both the inflammatory areas and most thyroid nodules appear hypoechoic, which means that a cancer may be obscured by the surrounding inflammation. In one case, the patient had left thyroid pain with a hypoechoic ill-defined lesion, fitting typical features of subacute thyroiditis. FNA was performed, and atypical cells were reported. 3 months later, the lesion had resolved completely on follow-up imaging. It can be difficult to distinguish between inflammatory cells and atypical cells on cytology. Therefore, it is best to make a diagnosis by considering both the clinical findings and the ultrasound features together. I hope this has been helpful. Thank you for your attention.